So what a great start. That was really an amazing session, and I think really set the scene for the next 3 days. The need to begin to blend discovery and innovation with the care platforms and to weave it all together with data that allow us really to iterate in real time. And I personally was very taken with the idea of failing fast. Tony, I don't know what you thought of the program.
I agree
it was amazing.
Completely. I think it was spectacular. I think it really highlighted the advances that have come in devices and how much progress we've made over the past decade in really coming up with ways to support the heart, to percutaneously insert valves, to develop leadless pacemaking systems, and so on. But I think notably, it's also highlighted that we have to catch up on the biological side of this, that we're still treating heart failure with the same 5 drugs, essentially, that we have for the past decade, with the addition of Entresto, I suppose. And so our hope, with the resurgence of interest in cardiovascular innovation, is that the pharmaceutical companies, the scientists, and so on, will be able to complement those devices with biological therapies that will help support advances and improved care. So I think for the next session, we really have something special. As I mentioned before, we're going to highlight really critically important clinical areas, and this session is about atrial fibrillation, which really combines the biology, the identification of genetic and other risk factors, as well as devices and procedural interventions. And to chair this session, we're very fortunate to have Singh, who is my good friend and colleague. Jag is the Associate Chief of Cardiology at MGH. He's also the Roman de Sanctis Professor of Medicine, and is the founder and director of the REACT program, which is the Resynchronization and Advanced Cardiac Therapy program. And in that context, he's had the opportunity to lead or participate in many clinical trials, either as a principal investigator or a steering committee member, so really has been at the forefront of developing novel technological solutions to cardiovascular disease, in particular electrophysiologic disease. So it's a great pleasure. Jag, thank you so much for doing this, and Jag will introduce the panel. Thank you.
All right, everything's working. Great, excellent. So Tony just told me that in case we go over time, they're going to pull the plug on us again. So without further ado, I want to first say what a pleasure and privilege it is to be here, to have this phenomenal panel with me out here, talking about a topic that is of immense importance to all of us. I think all of us in academia as well in industry recognize what a burden atrial fibrillation is to us. But let me first start very quickly introducing the panel, and so that I can then give you a little bit of overview on where AFib stands, and then we'll move on from there. So starting from my left, I have Patrick Ellinor, who's the director of the Cardiac Arrhythmia Service, and a leading biologist and geneticist in atrial fibrillation. Right next to Patrick, I have Colleen Fowler. Colleen is the Vice President and General Manager of AF Solutions at Medtronic. I have Parashar Patel, who is the Senior VP in Global Health Policy for Boston Scientific. And then I have Mike Rousseau, who is the President of Cardiovascular and Neuromodulation at Abbott. And then I have Steve Zelenkofske, who is the overall U.S. Medical Affairs Vice President for AstraZeneca for the entire cardiovascular side of things. So a very esteemed panel out here, looking forward to a really terrific discussion. But just about atrial fibrillation, I think just to set the playing field out here, since not everybody deals with this disorder on a regular basis, it's an arrhythmia which causes the heart rate to be irregular and drives the heart rate really fast. And causes a lot of symptoms to the patients. They can have palpitations or shortness of breath, oftentimes can go into heart failure, and are at a much higher risk for strokes as a consequence of atrial fibrillation. Just to give you an idea of the enormity of this condition, almost 1% of the general population in the US, about 3 million patients of atrial fibrillation exist at one point in time. And the projections are that by 2050, there will be about 12.6 million patients with atrial fibrillation. And as people get older, the propensity to develop atrial fibrillation actually increases, and the presumption is that more than half of the patients with atrial fibrillation will be above the age of 80 as the aging population continues to grow. Now, and then over and above that, anyone above the age of 40 has a 1 in 4 chance of developing atrial fibrillation over their lifetime. So for those of you who have not heard of it or have not experienced it, be ready to have a 25% chance of potentially experiencing it during your lifetime. So it's really common. Now, there are many treatment strategies for atrial fibrillation, and I'm not going to belabor the details, but one of the most straightforward strategies is to just control the heart rate in patients with atrial fibrillation, what we call as a rate controlling strategy. You move one tier up, and it's called rhythm control, where you actually put patients on medications that can actually get them back into normal sinus rhythm and hold them in normal sinus rhythm. And thirdly, there are catheter ablation strategies, that is, strategies that involve either freezing energy or heat energy to burn the circuits and prevent the triggers from setting off atrial fibrillation in patients who are predisposed to atrial fibrillation. Now, and beyond that, obviously, there are multiple strategies for preventing strokes in these patients, whether they're through medications or they're through device therapies. Okay, so that's just an overview out there. What I'm going to start with is I'm going to go down the line out here, ask each of my panelists to spend about a minute or two to really mention what is central to them in terms of atrial fibrillation. What are they most passionate about within this disease that keeps them going? So I'm going to start with Patrick. Patrick, thoughts?
Thanks, Jag, for the kind introduction, and it's certainly a pleasure to be here today with all of you. As Jag said, I think the things that are striking to me are the overall burden of atrial fibrillation. You heard some of the statistics mentioned by Jag. We actually think that the rates even increased a bit. It's about 1 in 3 for people over 40 now, when we've gone back and looked at those Framingham numbers. And that's a staggering number of people. There are as many people with atrial fibrillation in the United States as have prostate cancer in men or breast cancer in women. And yet I think that the amount of time and attention that we spend on trying to understand some of the fundamental mechanisms for atrial fibrillation is really just a fraction of what we've spent on those other diseases. So I think one thing that we've tried to do over the years is to really say, for a disease that's this common, do we understand what the inciting molecular triggers are? And the way we've done that is to go after and look at the genetic basis of atrial fibrillation. We've done that with large-scale populations to compare those with and without atrial fibrillation. And by the end of this year, we'll have the top 100 or so genes or genetic loci identified for AFib. So we'll finally have a fingerprint of the disease. And then it will be a lot of work, a lot of lab work, to try to understand, can we use that information in the clinics to stratify and identify patients earlier, or can we use it to try to understand in the wet lab what those different genes are, or can we use those genes as therapeutic targets? It's striking to me that of the genes that we've identified to date, none of them are the target for the current antiarrhythmic drugs that we use to treat atrial fibrillation. So I think from a research standpoint, trying to understand what are the pathologic mechanisms of the disease are critical. From the standpoint of my role as the director of an arrhythmia service, obviously AFib is far and away the most common thing that we're treating in any lab. And we'll hear a bit about that from Colleen and other members of the panel. But AFib ablations are the lifeblood of the arrhythmia service. And I think we need certainly refinement in our tools, not only for detection, but also treatment to make the ablation procedures that we have much more straightforward. So I think those are some opening thoughts.
Great. No, thank you. Thank you very much for that. And I think that'll feed off many of the questions as we move along. Colleen, your initial thoughts?
Thank you, and it's a pleasure to be with you here this afternoon. My passion around AF really comes around, if you know a patient or a person with AF, then you know how debilitating this disease can be and how it progresses over time. As we take a look at, I recognize this as a global audience, but if you take a look at the US spend in atrial fibrillation, it's about $26 billion a year. 50% of those dollars are actually spent in the hospital setting. So as we recognize, as we're all collaboratively working to try to improve not only outcomes, but how we identify these patients and how we treat these patients, The ability for us to be able to improve outcomes in this space is great. So as we take a look at how we're going to work together and from a Medtronic perspective, how we're approaching AF disease management, we're really trying to take a look at this from beginning to end. How do we improve outcomes in a complicated patient population? And how do we do that collaboratively with both payers and providers? So look forward to our conversation this afternoon. Thanks.
Great. Thank you, Colleen. Parashar?
Great. Thank you very much, Jag. Again, it's great to be here. Hopefully learn a lot from the panel today. My passion around AFib revolves around where I come from. I come from a payer world, financial perspective, and as Colleen mentioned, it's a big burden here in the U.S. and many other countries, $26 billion and growing. That's a cost to payers, but also to patients, families, caregivers. How do we reduce that? And, one of the interesting dynamics that we've seen play out here in the U.S., beginning to see it play out in other countries, is the notion of using payment reforms to change delivery systems. The question, I think, in my mind, we have to ask ourselves is rather than just sort of knee-jerk reaction, or we've got these new payment models, let's start applying them to diseases and conditions like AFib, I think we do have to step back and ask ourselves, is it the right condition to use with these payment models? Because if we go in the wrong direction, frankly, it can set us back, both in terms of supporting innovation, the type of innovation Boston Scientific does in medical devices, but also set back the care delivery system, the way care is organized and delivered, as well as, frankly, basic fundamental research in this area. So I think it's really important that we get the payment delivery system, the payment concept for AFib, if it should be different than what we're doing today, right before we set ourselves up for success in the future.
Great. Thank you, Parashar. Mike, your turn.
Thank you, Jack. When we think of atrial fibrillation, and we've been in this business a long time, first as Legacy St. Jude and now as Abbott, we put it in a short-term context and then strategically, how are we going to work through innovation and partnerships to ultimately solve this great problem, which is AF. So in the near term, we look very simply at improving the quality of patients' lives. That's what we're doing today. And I think we're actually, over the last 15 years, have made tremendous headway in managing this disease. As we look forward, we're also now beginning to look at extending patients' lives. And that's now become a reality in the current treatment modes. So as we look at innovation over time, a couple of things come into play. And it seems to make sense in such a complex environment as HF that the solution is also going to be just as complex. The idea that innovation on a go-forward basis for the sake of innovation is no longer practical or actually even relevant. So as several of the panels have discussed, I think that becomes the big point. As we look at innovation, it needs to solve multiple questions, not just the disease. First, it needs to be clinically relevant and proven in robust trials that, in fact, it's going to continue to improve patient outcomes. Secondly, cost. The idea that we can not look at cost as a primary factor on a go-forward basis relative to how we manage innovation is simply, again, not going to make us relevant in the space. And so these are the challenges that we'll talk about today on the panel, that there are multiple factors here in ultimately getting to the final goal, which is a cure.
Great. Thank you, Steve. Steve, your turn.
So I always get the last seat because I'm artist. So I from the drug side, I look at this and I say there's a lot of analogies to where we were decades ago in oncology, and the drugs we use are not very highly efficacious and they're quite toxic. They develop worse arrhythmias, they're poorly tolerated, and we haven't really had any advances in years. However, the technology around detecting atrial fibrillation has gotten so much better that we're now starting to understand the burden of the disease much, much better. And the approaches that we're taking are really anatomical and structural and going after it from a procedural standpoint, but we haven't advanced our understanding of the biology of the disease and how we attack the disease to really think of new therapies. And I think that atrial fibrillation is quite heterogeneous, that the causes of atrial fibrillation are probably multiple, and that if we try to attack it with big shotgun approaches like we did with cancer years ago, we're going to have poor success, and patients aren't going to be able to tolerate the therapy. So I think from a drug standpoint, we have to take a completely different approach toward the disease and really understand therapeutically where the biology of the disease is and how we attack it much more from a streamlined mechanistic approach.
Fantastic. So as you can see, the breadth and depth of this panel, we talked about genetics, clinical electrophysiology, ablative strategies, health policy, innovation, and drug therapy. So feel free to send across questions because there is an iPad. I'll be happy to entertain any of your questions because we have a lot of breadth and depth and we still have a lot of time to cover many of these topics. But let me start by, Mike, let me start with you. One of the things you talked about, innovation strategies and clinical trial strategies, it's always a little challenging the way we define atrial fibrillation. We try to lump atrial fibrillation as one disease entity. And when you're looking at solutions, you're probably looking at several different phenotypes. What are your thoughts on this particular area?
Yes, the one thing that we've learned through the years is that there is, for this complex disease, there's no one method that's going to be successful for every patient. We think that every patient actually is going to require a tailored therapy approach. And so when we think about AF and innovation AF, we think about a toolbox for the electrophysiologist. It's going to require multiple tools, whether it's catheters, balloons, advanced mapping, a new series of drugs, certainly new and extended clinical trials as we work through the issues, that there is no simple answer to a very complex problem. And so we see that you need a very broad perspective and, again, the creation of multiple tools that will ultimately continue to advance and then eventually get to the end goal of cure.
So Patrick, the way we currently classify atrial fibrillation as paroxysmal, persistent, chronic, do you think it's elegant enough that is going to allow us to, get into these individualized treatment strategies, or do you think that it's going to be tempered by genetics or other covariates defining this subset?
Yeah. It's a good question, Jag. I was giving a talk on exactly this last week or last Thursday to a group, and I actually showed the definitions of atrial fibrillation. I don't know if anybody has read these or is familiar with them, but I basically view them as kind of a joke. We can't even define the disease currently, meaning that paroxysmal AF is considered AF that lasts less than 7 days, whether someone gets a cardioversion or not. So it's completely dependent. I mean, it doesn't really translate into any specific biology. It's dependent on whether a doctor decided to do a cardioversion in 5 days or 8 days, or if it went away on its own. On the other hand, our definition of permanent AF is that it's considered a choice, a therapeutic choice by the patient and the doctor that they're not going to treat it anymore. I mean, these types of definitions, they don't really have any fundamental basis. So, I mean, I think you could start with something really simple like what are the different subsets of the disease? I think we know clinically what someone with intermittent AFib is, and we know what someone with permanent AFib is. There's a vast middle ground that's harder to define.
So the bottom line is we don't know what we're treating because we haven't defined it adequately enough. So that's a good starting point, I think, for atrial fibrillation. Let me kind of
speaks for the rest of our understanding of the disease.
Exactly, and I'm not even getting into the molecular underpinnings of trying to define this. So that's a whole level of complexity by itself. But let me. So we don't know how to define it. But what about the endpoints that we look at, Colleen? I mean, we try to look at all these curative strategies. I mean, should we be really defining treatment strategies for AF as curative or a strategy to actually get them into remission? What are your approaches on this?
Great point. I mean, most of the clinical trials, all of the clinical trials that are in this space talk about terminating AF, and anything more than 30 seconds of remittent AF is considered a failure in these trials. What we're learning now, both from a cost perspective as well as from a patient experience, is that lowering their AFib burden, so lowering the amount of time that they're actually in this arrhythmia, is very beneficial, not only to obviously the advancement of the disease, but also the costs of these patients coming back into the healthcare system. So as we continue to work and as we all continue to invest in clinical dollars to try to understand the mechanistic properties of how this disease propagates, we recognize that the endpoint maybe is something we should look at maybe a little differently collectively. And as we move forward, you'll see us all collect information on AFib burden as well as termination of AF and recognizing the values of both to a patient. But as we have said before, this is a complicated patient. It's often a patient that is carrying more than one disease. So when we take a look at heart failure or we take a look at diabetes, this patient that has AFib is often coming and presenting into the system with multiple cardiovascular morbidities. So as we take a look at endpoints for them, to put them into this narrow bucket of AFib is our responsibility and our goals, certainly from industry, is to help identify how to manage the therapy side of that. But we also recognize, as Mike said, we have to broaden ourselves to really recognize, in order for us to help them in the acute setting in the EP lab, we have to broaden ourselves and our understanding of this disease to be able to provide solutions earlier in their disease.
Oh, that's great. That's great. So Steve, do you think we as electrophysiologists, since you're one, are shooting ourselves in the foot by actually having these hard definitions of, calling an ablative strategy successful if they have freedom from 30 seconds of atrial fibrillation? Or do we need to be more liberal? Do we need to take into consideration quality of life parameters and more subjective parameters?
Well, it's, in a lot of patients, it's a highly symptomatic disease, and in particular, the ones who go for ablation, it's highly symptomatic, right? They don't end up going to ablation if they're not symptomatic, although there are tons of patients walking around with asymptomatic atrial fibrillation. It's probably almost half the patients are walking around with some form of asymptomatic, and then there's the mixture of both, right? So I know that when we see patients now as electrophysiologists, we want to set parameters that we think are realistic with our patients, although in our trials, we don't set realistic parameters. So we'll sit down and explain to our patients that we're trying to reduce the amount of atrial fibrillation they're having, try to see if we can get them off of their medications, see if we can take care of their symptoms. We try not to promise them that they're not going to have atrial fibrillation again. In particular, even with a successful ablation, the disease progresses, and at some point in time, they're likely to return later on in time with atrial fibrillation, unless it's very early on in the disease and it's an isolated AFib they're having. So I think having those kind of endpoints in our clinical trials probably is unrealistic because we're not setting those parameters with our patients.
That's great. That's great. So I think as we design future trials, we need to kind of make the definition of success a little more liberal and incorporate more, I think, patient satisfaction or quality of life aspects of things, and not just complete freedom from atrial fibrillation.
Well, it may also speak to the approaches we're taking, because if we realistically don't believe that we're going to make atrial fibrillation go away, then we're not necessarily convinced that we have the right therapies yet.
Right.
And so we're either in a situation where we are telling our patients we're going to put you into remission either symptomatically or with atrial fibrillation with the current therapies we have, or we're going to continue to evolve and try to figure out a way to approach atrial fibrillation differently so that we can offer them at least, if not cures, near cures.
Yeah, and I think a lot of it depends on where, at what point in time in their life cycle they actually encounter you for the first time, right? They could have had disease progression to an extent, and now things are not reversible, and they're way beyond the path of recovery. So just on that point, Parashar, when you try to systematize care along the life cycle of a patient of atrial fibrillation, I'd love to know your thoughts, especially from the payment perspective and how we can model different payment models, just looking at that entire life cycle.
Yep. So, one of the questions I think we talked about earlier is this a acute disease or acute condition, or is it chronic? And as you think about the answers to those questions, it can affect maybe how you want to treat the condition. I think from conversations I've had with folks on the panel here and others, there's certainly a chronic condition-like set of characteristics to AFib. And if you treat it as a chronic condition, taking into account the comorbidities you're talking about, maybe it makes sense to actually begin to pay healthcare systems money for treating the patient over the chronic condition. And recognizing at the same time that there may be some acute episodes within that chronic condition, which you might want to bundle together. So during that acute episode, they have an incentive to make sure the right set of care is delivered both during the procedure and post-procedure for a certain number of days, but then also go back to managing the condition chronically and using whatever set of combination of lifestyle modifications, drugs, other therapies, et cetera, during the course of the patient's life until hopefully at some point technology gives us the ability to actually cure the disease. So thinking about it more like a chronic condition may be something that we've got to do.
No, that's a really good point. And I'm going to break out into a question that has been asked by somebody from the audience about reimbursement for catheter ablation. And I'd love to get Mike's and Colleen's impression on this too. So I think from the payment perspective, with all the changes that are happening in terms of reimbursement, much of the risk is being transferred to the provider. And I think we are going to have to make decisions that we're not penalized subsequently for. What do you feel about the concept of reimbursement as we move along? Is it going to impact our redo procedures or not, or reinterventions? And how do you think we can all work together between the providers and the industry to kind of combat some of those issues that are coming down the pike?
Yeah, so that's a good question, right? So as a policymaker, one of the things folks might look at is the reintervention rate after an ablation. We did a quick analysis recently, and we found that beneficiaries have 25% of the beneficiaries that have an ablation are going to come back within the span of 3 years for at least one more ablation. As a policymaker, you look at that and some questions come up. Was it the right patient in the first place to do an ablation? Was it the right procedure? Was it done at the right time in the course of the condition? And if you want to drive decision-making on the part of clinicians to get better and reduce those repeat ablations, you might want to put this together into a bundle, right? And so if you think right now there's a lot of risk that's been transferred, I think more is coming. And this is why, though, it's important to make sure that we educate policymakers and payers as to, the ability, do you as clinicians have the tools to make sure it's the right patient, to make sure it's the right therapy delivered at the right time? Because if you don't, then it's a little bit out of your control, and you're doing the best you can, and you shouldn't be penalized. So I think those are some of the conversations that we need to start having, should have with payers and policymakers.
Mike, thoughts on that?
I think it's one of the great challenges of devices in general, and that is how is the value determined for both the patient, the technology, and the cost? Because when we look at devices, not just in AF, but in other areas also, the value delivered is over an extended period of time. However, hospital budgets occur annually. And so this is the dilemma that we're dealing with in how can we work together to figure out what is the best therapy, when is the appropriate therapy for the patient, and understand that the value delivery stream is not in sync with the payment strategy. So there needs to and obviously there's a lot of press and a lot of work and a lot of news right now about how in fact we are going to manage medicine on a go-forward basis. And this is an excellent example of the challenge.
Colleen, thoughts on that?
Yeah, again, I think it's the challenge that we all have in regard to redo rates around the world. There's no doubt that getting to these patients, it's been clinically proven that if we can identify these patients earlier in their disease path, we have a much better opportunity to be able to have a much better outcome in regard to terminating their AF. We need data. We need more data behind that to understand which patient population we can help with that. And in the U.S., again, U.S. statistic, as you well know, there is no on-label product for persistent AF. And so patients that are treated in a more advanced disease, we're doing our best with the tools that we have in regards to that patient population. So in order for us to be able to change our behavior with payers and with providers to say, let's go at risk with outcomes for this population, we really need data to be able to do that. I think we're certainly striving to be able to get data that we can then put behind our products and then be able to come and say, in this space and time, in this amount, with this outcome, we as a industry leader will come and share that risk with you on the outcome. But data is king in this space, both for early and late patients to understand where can we meet and where can we start that work together.
No, I liked your point about, kind of catching them early, recognizing them early, going upstream. And Patrick, for you is, how upstream can we go in terms of preventing atrial fibrillation either from genetic profiling or preventative strategies?
Sure. I mean, I think you bring up a number of good points, Jag. I mean, I guess when I look at ablations in general, I just wonder whether ablations for AF didn't exist 20 years ago. Right? I mean, they just weren't there. And, I have to look and say, in 20 years, will they still be there? I mean, when you look at ablations, they work. They're obviously, as I mentioned earlier, the lifeblood of all of the arrhythmia service and academic medical centers. But they're pretty barbaric. When you think of it, what we're actually doing is cauterizing sections of the heart to treat atrial fibrillation. And I think it bespeaks, the reason we do them is because it works, right, for a large subset of patients. I mean, yes, there are redos, yes, there are potential complications, but it's the best that we have. And I think that's really where the challenge is to say, can we do something better than that? If we understand the disease better, can we identify, be it better therapeutics or shorter ablations that are easier, better tolerated, or both potentially? When you talk about going further upstream, I think one of the most interesting things coming our way is a bit of what we heard this morning with the large-scale screening. Can we just detect AF more readily in the entire population? And I think that's coming probably in the next just 3 to 5 years. I mean, I think that's pretty straightforward. AF is, of all of the devices or all the diseases you can pick up on a wearable, AFib is one of the easiest to pick up. I mean, it's pretty straightforward. You can see it on a watch. You can see it on an iPhone app. So what I see coming is within a few years, every one of your parents or grandparents is going to have a watch to screen AFib and try and pick it up before they ever have a stroke.
So let me take that a little further.
Sure.
Isn't, once you had AFib, it already kind of indicates that some of the changes that needed to happen within the atrial microarchitecture have already happened? And I'm going to ask Steve to answer that question since he's nodding his head out there, and then get back to you.
Sure.
No, I'm agreeing with you because I think that we do have much better devices for detecting, and we could possibly detect earlier, but we've been for a while trying to see, can we identify upstream before somebody has atrial fibrillation who's going to have atrial fibrillation? So is there a biomarker? Is there an electrical marker? Is there something that we can use to say this is somebody who's at risk for developing atrial fibrillation and intervene before that? And we know that there is suggestions that very early lifestyle modifications can potentially delay onset of atrial fibrillation, although it's hard to know that from the data we have now. But things like obesity and hypertension are highly related to the incidence of atrial fibrillation and potentially identifying those people at risk. Those are easy interventions, although I would suggest that when we figure a little bit more out about the biology of this and we understand markers to identify people at risk, we may be able to intervene beforehand. And if we can, we then can prevent progression of the disease to a real disease. We learned early on in electrophysiology that AFib begets AFib. So the more AFib you have, the more AFib you're going to have. But it doesn't seem that once you have atrial fibrillation, if you prevent it, that you prevent it from occurring. So I think that almost the cat's out of the bag at that point once you've identified that they have atrial fibrillation. So we need to figure out how to get there earlier, how to get there before it.
So let me be a little provocative out here. I mean, you said that there are certain lifestyle conditions that predispose you to atrial fibrillation. They can be an elevated BMI or they can be sleep apnea and the like. Do you think we are, since now with all the risk being transferred to the provider, do you think we should be insisting that patients actually modify all their reversible factors before we actually take them down an invasive procedure where the impact and the success of that procedure will be largely limited because of their lifestyle choices? Mike, you want to take that on?
We don't have anybody left.
I really thought Patrick was going to get that.
Okay, Patrick, go next. Patrick, where did you
So,
go?
When I was mumbling under my breath,
yeah,
we don't have anybody left.
I mean, everything I did in college, I shouldn't have, right? So the idea that, and several panelists already mentioned it, and that is the innovation in patients participating in their disease and in their health is advancing at an incredible pace, far beyond anything it has in the previous 10 or 15 years. And the idea that people are now tracking their health even by step or by arrhythmia is very common. And so I think the tools are now in place for people to actually not only take care of themselves at a far earlier point from a prevention perspective, but then also to be able to be an active participant in managing the disease on a go-forward basis. And I know that everyone in healthcare, as well as outside of healthcare, is focused in this area. So the enabling tools are in place. It's how quickly the adoption will occur.
Well, let me be a little more provocative on this front again. Parashar, as we talk about payment models, should they include aspects of lifestyle changes, modifications as a part of the whole payment model? Have you insisted? Have you checked off that box, yes or no?
So we're there in certain places already, right? There are some payers that will demand for knee replacements that your weight be below certain levels before you get the knee replacement done, precisely to improve outcomes. So I could see the day where payers and frankly physicians will, maybe not demand, but lay out what the outcomes for you are based on where you are with your hypertension, for example. So geez, if we can bring this down to this level and then we do this, we'll have a much better chance of success. And frankly, it's good for the patient. How you do it and what the conversations are and maybe what if there are incentives in place, I think those are all questions that we've got to ask ourselves as a society, as stakeholders in this. But ultimately, leave it up to the patient to decide. If we're going to be serious about patient-centric care, it really will be up to the patient to decide.
So Colleen, just to kind of take that a little further, the industry is getting involved in disease management strategies, right? They're looking at diseases. They're not looking, as Mike said, just at one tool to take care of, ablations, but kind of looking at the entire life cycle of a patient. How is Medtronic, how are you, or how is the industry thinking about doing this for AFib patients? Can they track patients right from their outpatient setting to their inpatient setting to their in-home setting and make sure that their care in the entire life cycle is in some way integrated so that it can make their care reasonable and make sure that the payment models are all in, cahoot with this?
Yeah, no, if you take a look at the risk modification, the behavior modifications that we're talking about for AFib patients, it's really the same for their entire cardiovascular health, right? So because these patients often present with cardiovascular disease, heart failure. When we talk about risk modification, from a Medtronic perspective, we're really looking at that not just as an AFib patient situation, but across all of the cardiovascular portfolio at Medtronic. So as we take a look at how are we going to put together earlier identification, better education, recognizing what sleep apnea means to an AFib patient specifically, exercise, alcohol, all of the things that line up in regards to prior to us intervening at all on these patients, either with drug or with an intervention of an ablation. What can we do to make sure that we're identifying them and that they're educated and that we're supporting them with some sort of a clinic or some sort of ability for us to provide education? And then whether we can support them with the drug management, whether we support them then with understanding from a risk stratification, which patient actually is going to benefit from the ablation, which if we had a payer sitting here, we would be saying, they want to know they don't want to trust to treat all AF. They want us to treat AF patients that we can help. So as we start to build data there to be able to understand those questions, ultimately at the end is the monitoring. How do we monitor these patients? We currently, from a standard of care, can have continuous monitoring on this patient population, but if we take a look at it from a disease management perspective, we should, and we think we should. So again, how we are lining all of that up to be cost effective and to be actually able to provide those individual solutions are in silos now. Now the opportunity is to try to blend that and be able to provide a solution to a provider or to a payer that allows us to be able to take care of the patient as a whole.
So I think you have the monitoring figured out, you have the ablative strategies figured out, but the drug therapy doesn't seem to work. Steve, why don't drugs in AFib work, and is there any hope on the horizon?
No, I think you're right. It sounds to me like we're coming up with a device that's going to ablate their obesity, their sleep apnea, and their AFib at the same time. We just invented something new. But no, we really are way behind on drug therapy, and I think the work that Patrick's doing and some of the other folks are doing to understand the molecular basis for disease, the genetic basis for the disease, I think is going to change the approach we have. I think we have gone after the electrical approach toward the disease and going after channels. And it appears, at least from understanding the molecular basis for disease and the genetics of disease, that we probably have gone after the wrong channels. And the problem on the drug side has been that it's really been a graveyard for drugs. Every drug we've developed generally has a lot of toxicity, whether it be making worse arrhythmias than the arrhythmia we started with, called proarrhythmia, or drugs that have organ toxicity or poorly tolerated. These drugs are highly toxic when they go after the channels we've been going after. So they're not well tolerated, but on top of that, they just don't work very well. So we accept 50% reductions in AF, and when you do placebo arms in these studies, about 25-30% of the patients who get placebo will have reductions. So we're really getting like a 25% placebo reduction of their atrial fibrillation, which is extremely poor with somebody who's got a highly symptomatic and highly recurrent disease. And it just tells us we're going after the wrong target. So I think there are some innovative programs now saying, let's go back to the basics. Let's understand the basics of this disease. Let's figure out where it's coming from. And let's see if we can go after targets that are much more exquisite, that actually work. And it may be that, and I really do believe this, that we're not going to come up with a cure-all drug for atrial fibrillation, that much like, as I started before, saying how oncology has approached cancer, not all lung cancer is the same. Not all AFib will be the same. And it may be that there are certain AFibs that will respond very nicely to certain therapies, but not to other that other AFibs won't respond to that therapy at all. And I think that's where we're going to be much more successful, to say, let's take the smaller subsets of AFib and try to get wins that are much more highly efficacious and a lot less toxic.
Absolutely, absolutely. I think very, very good points. one place we do have drugs and devices are in stroke prevention for atrial fibrillation.
Yes.
And they work really well. And I've got like 5 questions out here from 5 different people asking me to ask about stroke prevention. So Patrick, do you want to kind of give an overview as to where device therapy as well as drug therapy has evolved in stroke prevention for atrial fibrillation?
That's a nice short topic.
You have a minute and a half. You're already on the yellow light.
30 more
Already
seconds,
on the yellow
no
light.
problem.
Or they'll pull the plug, remember that.
I have plenty of time. Yeah. Certainly the new anticoagulants, the novel or oral anticoagulants have really been game changers in the field of atrial fibrillation. I mean, the only drug that we had from, Ike's time as president was warfarin all the way through to present day. And we know the limits of warfarin. The 4 NOACs that are available have dramatically changed the ease at which you can treat patients. There's always the trade-off of bleeding risks, but I think that they've been incredibly effective at changing our ability to rapidly and effectively anticoagulate people. As a group, they're safer than warfarin, and I think if you were to put warfarin up again today, it's really just the cost that's keeping warfarin in the game at the moment, is that some of the drugs are just less affordable for the patients, but that's a short-term problem. So these drugs have fundamentally changed our ability to treat and prevent strokes, but despite that, I think we still face in our populations the big disconnect between the patients that we know today should be on an anticoagulant and those that are actually receiving it. And as you know, it's at best case scenario, about 2/3 of the patients that we know have atrial fibrillation, have risk factors for stroke, are actually on an anticoagulant. And some of that is patient preference, doctor preference. There's not one simple answer there, but it's a big challenge in the field.
And what about left atrial appendage occlusion devices? Any thoughts on that? I know your division section implants a fair number of those devices.
Certainly do. Some of my colleagues do quite a number. And, I think those are one more tool to add to the armament that we have to try to prevent strokes for atrial fibrillation. But I don't think that they'll have the same broad base that you're not going to be able to put as many of those in as you would be able to give some of the oral anticoagulants. So I think they're great for specialty populations. If you have patients who have had recurrent bleeding issues, if you have patients that are intolerant of the drugs for other reasons, if they had an intracranial hemorrhage, they're great replacements. I don't know that I would necessarily view them as a complete replacement for all patients on anticoagulation at the moment.
That's terrific. We have less than a minute and a half, so let me just ask, going round out here, I'll start from you, Steve, this time. Optimistic about the future for treatment strategy for AFib, or kind of neutral?
No, I'm optimistic. I think we're starting to realize that we haven't taken the right approach, and I think we're starting to, I do think that we've made a big difference in ablations. With ablations, we made a big difference with our oral anticoagulants, and I think the next revolution is going to be to figure out how we can understand the disease better and start to streamline our therapies to get better successes with some of our therapies. So I'm quite optimistic that we're going to get there.
Great. Mike?
Yes, I'm also very optimistic about the future. There's so many advancements that are happening, not just in this area, but in other areas that allow us to share in that innovation and to bring that into play. And because of that, whether it's predictive medicine, whether it's the tracking technology that we've spoken to, as well as the advancements in mapping catheters and so forth. Since I've been at this almost 30 years, I probably have a different perspective than a lot of people, because I remember where we were and where we were 10 years ago, even 5 years ago, and where we are today. We are clearly in an incremental way, I think, and that's how this will sort itself out. It will be incremental innovation to get us there, but we remain very optimistic.
Right. Parashar, you think we'll figure out all the payment strategies?
I don't know about that, but I am optimistic in terms of, advancing care, right? So we talked a little bit about trying to make sure we have better fundamental understanding of the disease state, which leads to data, which leads to the predictive analytics to make sure we're targeting the right patient early on. And then I think some of the innovation that we see in care delivery systems, right, in terms of care management, putting some of that data to use, combined with payment delivery changes that optimize that type of care delivery. At the front end, and, at the back end, we talked about the NOACs, Watchman, and other devices for those patients that may not be amenable that we don't catch. If we get progress there, I think we'll be in a better place 5 to 10 years from now.
Great. Thank you. Colleen?
Yeah, no, clearly I'm also very optimistic about the space and what we can do for patients. There's just a tremendous amount of innovation happening in our companies as well as outside of our companies. With the population rise and the number of patients that there are to treat, there's a tremendous amount of really strong engineering work that's happening. And so, as we progress from our perspective of making sure that we're taking care of the patient and with acutely as well as upstream, but also recognizing our value and our responsibility to payers and to providers in the space as we really take this next step forward in looking holistically at atrial fibrillation.
Great. Patrick, you have the last word.
Well, I think the next 10 years are going to be a lot of fun. I mean, you go back and it was only 20 years ago that we realized that AFib arises from the pulmonary veins in a lot of patients. That led to an explosive growth in ablations. And then you saw the game changers that we had with the NOACs that came online. Now I think the big areas are going to be screening in broad populations, understanding the subsets of AF, and then trying to take some of this genetic information and use it as therapeutic targets. So I think the next 10 years we're going to have plenty to do.
Great. And on that optimistic note, I want to thank the panel, and I want to thank you all for your patient listening. Thank you.